Here comes the fun stuff. So, question for you. Doctor is a Latin word. It means teacher. I always love sharing with my patients. So when's the last time a doctor taught you anything? So talk to your patient, and if you hear me when I'm talking to you, I'm trying to tell you how I communicate with my patient. But talk to them, get their feedback, listen to what they're saying. Tell them what you're doing with each test, what you want to look for, what you're trying to find, and when you're treating them, talk to them. Here's what I'm trying to achieve. I want to take this and move it this way. I want to alter this that way. So have a conversation with them. But here's a question for you. What will it take to overcome a lumbar disc herniation? Okay, I had a 70-year-old patient who was referred to me by a neurologist with a disc herniation. He's 70. His discs should all be pretty compressed by now, but they're not. He's got a disc herniation. And so the doctor told him, no, I'm not doing surgery. I want you to go do acupuncture, chiropractic massage, do everything, and I'm your last resort, which I was like, yay. Talking with a doctor here earlier today, he was telling me how his conversation with the neurosurgeon was that people who get disc surgery are tourists. They're coming through to see, oh, what would this be like to get this done, versus being patient and allowing the body to resolve that on its own, or even better, going to a chiropractor and getting it fixed. So this is a question that your patient has in their mind. What's it going to take? How am I going to get there? And actually, they may not have that question in their head, so verbalize it for them. You know, Mr. Smith, you're in here today. Your doctor sent you because you have a disc herniation. What's it going to take to fix you? What will it take to get you there? And of course, their answer is, I don't know, that's why I'm here, but I want them thinking, we're overcoming. We're finding the solution. You're not stuck here forever. This didn't come to stay, this is coming to pass. What was really interesting, and we're going to go through something here, we had a nice conversation with this gentleman. He actually introduced me to the inflatable lumbar belt, and pretty amazing result, and we'll talk about that more as we go along. Really amazing stories and stuff that's going on. Our goal in treatment, what are we wanting to achieve? What do we want to have happen with the patient? We got them coming in, we've got a disc herniation, we'll just say it's verified MRI, total antalgia, positive Valsalvas, we're a full-blown disc herniation case, radiating symptoms, all that. What do we do? What can we do? Well, first of all, we want to reduce that nerve pressure. We want to get that nerve free, all that stuff. That's our goal. However we can do that, that's the goal. So we want to unlock joints, get them back to slide and glide. We want to reduce muscle dysfunction. If we know that healthy muscles are strong, flexible, and pain-free, and we find that they're not there, we want to change that. We want to restore normal muscle power output, take it from a weak state to a strong state. We want to correct those motor control errors, that inappropriate sequence or that reduced neural activation. We are nerve doctors. This is where we live. We want to change the nerve function. Where we find muscle fiber adhesions, let's detangle them. Let's get that muscle functioning well so the bones are in good alignment and being held there without the muscles creating all that distortion. If we have disc bulging, disc prolapse, we've got extruded material out there, so we want to either encourage that disc to resect or to be reabsorbed. Okay? So, traction creates that vacuum decompression to help suck disc material back in. So that can be very helpful. And then we also talked a little bit about the proteolytic enzymes being a potential helpful for that. With all these options, we want to look at what risk factors there are with what we do with each patient, because some things that work great for some patients may not work for others. Our high velocity adjusting, you may or may not want to do that. If you've got somebody who's potential cauda equina, probably don't want to do this for certain. We can use adjusting instruments, and I would tell you, even on that cauda equina patient, with your adjusting instruments, you're probably going to be tolerable enough that you're not going to aggravate that person. So, you know, as a professional, if you feel it's appropriate to adjust that patient and then refer them for either an MRI or surgical consult, let's keep that in mind. Your soft tissue techniques, what I want you to understand about soft tissue techniques, you can either turn that muscle on and make it engage and work normal, or you can shut it down and make it go into a guarded state, depending on how you approach that neuromuscular connection. Traction and spinal decompression, excellent, great therapy. You know, there are some precautions, but overall for disc herniations, This is an awesome, awesome tool. There are braces and supports. We're going to talk about some of those. There's some really cool ones that I'm going to share with you today. There's specific exercises that we can do with these patients. They can't move, so they may not be able to go to the gym. We can still exercise them and strengthen them. Obviously, you've got some therapeutics you can do and nutritional therapy. So evaluate what's going to work appropriate, know what works for you, and by the way, know who else to refer to, because you've got colleagues who have skills you don't, and somebody may be better at something else than, or that patient may need benefit more from someone else. My treatment protocols, my objectives and what I'm looking for with a patient, I have this premise in my head that healthy joints slide and glide freely. There should be no problem. They all move. Healthy muscles, strong, flexible, no restriction, no pain to touch. If anything's painful to touch, there's a problem. That's an issue. So we want to decrease joint and muscle tension. One of the ways we can do that is by stimulating the Golgi tendon organs and the muscle spindles effectively, correctly, appropriately. We want to balance that muscle power output quadrilaterally, front to back, left to right. Everything working stable. We can use measurable outcomes to identify this and monitor this. What I want to tell you is results in my world should be immediate and progressive. So immediately in this visit, I should see significant changes, and from visit to visit, I should see that not only holding but improving. We want to restore that filament sliding action in the muscle fibers themselves. Those actin myosin filaments, we want to get those where they're all locked up. We want to detangle that. And again, we want to detangle that in a way that's tolerable to the patient. You can go in and do all kinds of other stuff really aggressive, but that may not be helpful for the patient. So how do we locate where the joint and muscle dysfunction are? What I've shared with you today, the protocols I look at is, I look at my palpation, and we're going to talk about some palpation stuff in a little bit too. We look at movement analysis, static and dynamic, and of course, I'm a big, huge proponent of muscle testing because it shows me exactly what's going on neurologically. Where's the nervous system working? Where is it not working? Correcting that muscle dysfunction, the Golgi tendon organ stimulation is at the origins and insertions, where the GTOs are, and the muscle spindles are in the belly of the muscle. Our results when we work on somebody, I don't care what your technique is or if you're using instruments or whatever, your pre and post testing of your range of motion and muscle testing should validate not only to you and the patient, but as well as the insurance company, that they're better. In other words, when the patient gets up off your table, when they get up off my table, I want them going, yes, I'm ready to go. I'm freer, or at least I hurt way, way less. And I want to be able to document and validate. My mentor, Dr. Van Dusen, practiced till he was 88 years old, and then he passed. Genius guy, really amazing. He taught at chiropractic college back in the 50s. And one of the things he did, he wrote a book. He was actually part of the group of people who developed the DACBAR program, the radiology program for chiropractors. So he did a lot of stuff with radiology. And one of the things he did, he actually built this platform that had a couple different rotary devices that made the platform kind of tilt and angle at different things. And then they'd line people up on the x-ray thing, and they'd try and line up L2, T2, and C2, or something along those lines, and look at, create that as their center line, and then anything that was distorted off from that was a problem. Well, in doing all this research and teaching at the school, he said, you know, I'd have this theory, I'd get out on a limb, and then the student would cut the limb off, and then I'd have to climb back up the tree and find my new limb. What he found, though, was that muscles move bones. And if the muscles are dysfunctional, then we're having spinal distortion, we're having bony misalignment. And if he could correct those muscles, that spinal misalignment disappeared. So he didn't have to do this horrific traumatic movements. He could really make changes just changing the muscle function. So one of the things that he emphasized was search for the primary cause. Doctor mentioned that earlier today. We want to find the primary cause. Well, if we're looking at this musculoskeletally and we're seeing muscle dysfunction going on throughout the whole body, what I want to do is look at the major muscles first. They're the big movers. For example, we talked about the hip flexors. Well, the big one in there is going to be psoas. So if I test the hip flexors, I'm testing the big major ones first. And if they're failing, then it's the little ones that will pop up and they'll reveal themselves. If I'm looking at the lat and I see that the lat is weak, I can go to the spine and I can palpate the spinous processes from T8 all the way down to sacrum. Left lat is weak. I go to T8 on the left side and I just start hitting those spinous processes until I find the one that the patient goes, yeah, that one. Now I know where I'm working. Press in, couple nudges, hold. I can do a little movement if I want. I'm more specific, and then I can document more clearly exactly what level I'm at. Understand with your SI joint fixations, and those people who've got SI problems, it could be a lat. It could be that lat coming in. The problem may be way up in the belly of the muscle here. We want to locate the tender insertion regions. Is it tender at the origin or at the insertion, or is it tender in the belly? What we want to do is we want to correct into the osteotendinous junction at the tender end. If both ends are tender, then they both need corrected. What I'm going to tell you is we want to correct into the most tender point in the direction of most sensitivity. This is the source of injury. This is where it's at. So if we can find that. Now here's the challenge. I'll show my patient, here's where you're tender, and so they'll touch it, and the first thing they want to do is what? They want to rub it. Well, what does the rubbing do? It's actually irritating, and now it makes that muscle go into a guarded state. So we don't want them to go to a guarded state. We don't want their muscles to be weaker and shut down. And then we want to look at the muscles in that chain above and below for any distortions there. So if I've got a hip abductor issue, somebody told me they stepped off the curb and missed the step and they got that pothole syndrome going on. They might be having pain here at the acetabulum, so we work in the abductors. But I might also have to look at the calf and the QLs and the obliques because that whole chain is involved there. Think about the auto accident patient. Where's the hands? All the way to the spine. So on your auto accident patients, evaluate upper extremity all the way through. Where's their foot? Probably on the brake. All the way up through that chain. Look at all that stuff. Correcting neuromuscular dysfunction. So manipulation of proprioceptors will increase or decrease tension and muscle power output based upon how you stimulate. You stimulate the right way, it goes this way. You stimulate the wrong way, it goes that way. So what I have found is that when I stimulate the Golgi tendon organs, I'm going into the origin insertion and I watch the muscle tension decrease and the muscle power output increase. And their pain goes away, or at least it reduces significantly. In the muscle spindles, in the belly of the muscle, what I found is if we use a perpendicular alignment to go into those fibers, we get a better correction. So talking about the bicep fibers, they're running superior to inferior. Perpendicular is this or even this. Okay? What I don't want to do is this. Okay? That's going to shut stuff down. So my protocols are go to the origin insertion, press directly into the osteotendinous junction at the site of most sensitive tenderness, muscle belly, do perpendicular. Do not pull muscles away from insertion points because that makes muscle power output decrease. Do not use circular grinding motions. That stimulates muscle guarding and increases tension. Does anybody want to experience any of what I'm talking about? Go ahead and curl that in, curl that in, curl that in. Hold and test and hold, 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 hold. Did I beat him?
A little bit.
Yeah. 2 to 3. Okay? Let it go. Let it relax. Let it relax. Rest that down. Bicep attaches up into the coracoid process, which is tender.
A little bit tender.
1001, 1002, 1003. I'm holding him for 3 seconds. Let's see what happened. Curl. Hold. What happened? Patient says, "Doc, I went to the massage therapist who massaged me." Hold.
Yeah, I can feel it already.
"Do you like your massage therapist?" "Oh, I love him." "Great, send him to me so I can educate him." Massage therapist comes in and I tell them, "I don't care what your technique is, do that first. When you finish," because I'll do this to him, I'll shut him down. "When you finish, go back at the origins and insertions," let it relax there, "and push right into that insertion point. Hold." And just hold that 3 to 5 seconds. Or if you want, you can do a little nudge, or you can take your instrument into it. They may not have an instrument, but I'll just teach them, hold. Don't destroy my patients. Hold. And he's back on. Challenge me. You have questions.
How long does it last?
Good question. How long does it last? Let's see. Are you still there? Hold that. Hold, hold, hold. That long at least. I tell my patients, I expect this to last at least 24 hours. So if I see you tomorrow, I expect you not to drop more than a grade. If you're dropping more than a grade, what'd you do?
Saw the massage therapist.
I saw that, yeah. I have a story for you on this. So what'd you do? Nothing. How many of you had patients said they did nothing, right?
Nothing.
So back pain, dog my back. Okay, good. Come in, lay down, work on him. He's feeling really good when he leaves. Oh, yeah, really good, doc, thanks. So you know what, you're not stable, you're not 100%. I don't want you to really do much, and you know, come back, let's see you tomorrow. Okay. So he comes back in the next day. Doc, I don't know what you did to me, but I'm worse. I'm like, well, you were feeling good when you left yesterday, right? Yeah. Well, how long did that last? Oh man, I felt really good. I mean, that lasted until, you know, late into the evening. I said, well, what'd you do? Nothing. So in my head, I'm thinking, okay, you sat on the couch in a really awkward posture for hours watching TV or something. I said, so what, were you sitting on the couch or doing what? He goes, well, no, you know, I'm a backyard mechanic. I have this truck I was fixing, and so I changed the motor in the truck. So you put in a new motor, yeah. So you tell me you used a winch to pull the old motor out, and then you put the, oh no, it's just a little four-cylinder. I just reach in and pick that thing up and pull it right. I said, they're about 200 plus pounds. He goes, oh yeah, I do it all the time. I go, oh my God. Do you think that might have aggravated your back? You know, come to think about it, my back did start hurting after that. And you did nothing. All right, there's my nothing story. I love it, I did nothing. So, I do expect at least 24 hours. I expect that to not degenerate too badly unless they're doing something to aggravate it. And when I see it degenerate really fast, then I gotta have questions with them. What'd you do? What's going on? What's your postural challenge? What's your dietary challenge? What activities you're doing? Something going on. Could be the car seat they're sitting in. I have a whole company that I work with a lot of the people in treating them, and they have drivers, and the Ford, I think it's the Ford Fusion car or whatever, they all have these kind of cars. They just bought them like in the past year. I've got at least 3 or 4 of them coming into me regularly because these seats are so bad, tearing them up. Actually, one of my good friends who's a dance instructor, his hip is all dysfunctional. He's got a Ford pickup truck. I'm not saying don't buy a Ford, but their designers might be chiropractors trying to increase business. That's my attempt at humor. So some protocols and things I want you to have in your head when you're working with patients is how much pressure do we use? How do we gauge that? If we got somebody with acute pain, and when I'm talking acute pain, you just had the car accident, you're hot, you're red, you're swollen. This is the 2+, I can barely touch you. Also think about the person who just ate turkey Thanksgiving dinner. Thank God that's coming up soon, right? And they're so bloated that, oh, don't even look at my stomach, it just hurts. So what do we do with those patients? We just touch and hold. So, you know, Miss Smith, I want you to touch where it hurts. Oh, no, it hurts too much. Well, I'll tell you what we're going to do. We're going to touch that spot. I want you to touch it with one finger in the lightest way possible. You mean like this? Yeah. Oh, that's it. Oh, yeah, that's it. Yeah, just touch that. Okay, that's the spot, yeah. Hold that. 5 seconds later, how's it feel now? Oh, that feels a lot better. Acute pain, gentle hold and touch. And so for myself, I'll go, oh, that's where it's at. How's that pressure? Oh, that feels good. Good. I'm just going to sit here and hold. I'm going to let that nerve irritation and firing attenuate and just.
What is EBT?
Eccentric brake testing. So that's the acute pain. Touch and hold and let it come down. And that's also, you'll probably want to use cold or ice. It's really nice when my hands are really cold and then I touch them. For chronic pain, find and grind, pin and stretch. So basically, with chronic stuff, they've got it long term, it's been there a while. This is a real good point where we can go find where the muscle fiber is a little irritated, pin it down, and then just do some mobility there. So what I tell my patients also, so Mrs. Jones, this is where the spot that really hurts, right? Yeah, so touch that, good. And she wants to rub it. Don't rub it, touch it, hold, and now what I want you to do is start moving the body part. Okay, and then we got to pin and stretch, and now we're not coming on and off that button, we're just staying on the button in a very tolerable way. Again, with muscle cramps, we're going to squeeze them, hold them till that stops firing, and then tell the person, here, have some water. With every technique that you have seen, heard, know of, or may find or hear of, there's some critique questions that I have for every technique that I've seen. So where do you fix? How do you know where to fix what you got? You know, what's your analysis? How do you know what needs fixed with the patient? For me, the way I find it is I look for the weak muscles, that neuromuscular dysfunction. Where's the nervous system shutting stuff down, locking it up? That's my eccentric brake muscle testing. How do we fix it? Well, for me, as you've heard, I'm going after the GTOs and the muscle spindles very specifically. How much force do you use? Again, I'm getting feedback from the patient on their tolerance level, because what one person can handle, the other one may not be able to tolerate. I want to make sure that I avoid the guarding response, which means I try not to use pointy fingers. Pointy fingers are really great for finding where the issue is, and then we soften up the touch a little bit, so it's not so irritating and we don't trigger that guarding. How long do you work on them? You're done? Yeah, you can do that. You're high velocity, you're done, that's it. That is your move. For me, I'm going to change that neuromuscular dysfunction. I'm going to go and hold, I'm going to go 3 to 5 gentle presses. I'm going to do a hold 3 to 5 seconds, or I'm going to do pin and stretch about 3 cycles. And then I'm going to go test. I expect to see immediate results. If it didn't change, I'm missing something. I am missing something, not the patient. This is on me. It's on me. I'm missing something. I'm going to find this. When do I stop? So if I've retested them and they went from a 1 to a 5, I'm pretty good. If they went from a 1 to a 2, I'm going to go look a little bit more, see if I can get more. I'm going to do the same thing a little bit more, see if that gets them more. If it doesn't, I might have to go look at the chain. Something above or below might be affecting that. And then if I go correct that, boom, it all comes on. So what if we do all that and nothing changes? Because not every technique is going to work for everybody and every time. So what do you do when your technique doesn't work? Well, for me, I'm going to take and I'm going to find where that tender spot is, and then I'm going to put pressure on there, and I'm going to hold, and I'm going to change my angles to find the one that makes the muscle go weak to strong. And now I know which direction I want to go, which is really good when you've got an area where you've got multiple muscles coming in and they got different angles. Here's the bone, this muscle's coming up to the bone at this angle, and this muscle's coming up to the bone at that angle. And so if I'm pushing this way, this one's probably going to shut down. That one might be really good. So depending on which muscle is dysfunctional is going to determine which way I want to push.
One thing I do is I'll change technique and go, there's different treatment points. There's a muscle treatment point, then could be a spinal treatment point that's directly associated.
Yes.
And so I'll change technique and use maybe activator on the spine.
Yes.
And it may get better results that way. So.
Yeah, and so anytime we can go back to the spine and look at stuff, that's great, because that is more at the root. We're looking more for the root cause of stuff. Yeah. What if you still don't observe changes? Now what do? Nothing's happening. You've been working on this patient. I actually just got a patient 2 days ago, concussion patient, sent to me by another doctor who's been working on her for 3 months with massage therapy. And this girl, just like she was in an accident today. I mean, acute, can't touch, everything's all inflamed and fired up. And it's not that the doctor and the massage therapist didn't do good treatment. What they didn't do was ask the patient, what's your diet? I'm vegan, and I've had a horrific car accident. My body is now in a traumatized state. My muscles and my structures are dysfunctional. And that means you need protein to rebuild. And it's really tough for vegans to get protein in. And so we had that conversation. Yeah, hard to make progress when you don't have the building blocks you need. And then so the other thing is looking up and down that chain, looking for other stuff, what's going on there.